Hello, everyone. I'd like to welcome those who are connecting to our webinar on Sleep Centre Accreditation, where we're going to talk about the new Sleep Society guidelines. First, I'll tell you who I am. I'm Sarah Hartley. I'm a French sleep physician. I work in Paris. I'm on the board of the French Sleep Research Society, where I am responsible for accreditation. And I've had the honour of being the lead of the ESRS Working Party on Accreditation, and with the help of an incredibly dynamic team, we've managed to put together a revision of the 2006 guidelines, which were put together by Dirk Pevenaggi, who's going to talk first. I should say that I have got no conflicts of interest to disclose when it comes to this activity. So I'm very happy to present you the programme. First, we're going to have a talk from Professor Dirk Pevenaggi. I think pretty well everyone probably knows Dirk. He's a sleep physician, a pulmonologist. He's Vice President Chair of the European Sleep Research Society, and he was the first co-author of the initial guidelines in 2006. And he's really uniquely placed to tell us how sleep has evolved over the past 20 years. After that, we're going to have a presentation from Professor Dr. Thomas Penzel. As you know, again, I think everyone knows Thomas. He's a sleep scientist, chair of the Sleep Medicine Committee of the European Sleep Research Society, member of the Accreditation Working Party, and a big thank you to Thomas, who worked very hard on improving the previous guidelines, secretary of the German Sleep Society, chair of the Professional Activities Committee of the World Association of Sleep Medicine. And as I say, he's going to talk to us about the overall structure of changes. And lastly, Professor Johan Verbraken is going to talk about the details of criteria by level. And Johan has been an incredibly important member of the Accreditation Working Party. He's a sleep physician, a pulmonologist. Again, I think everybody knows him. Coordinator of the Multidisciplinary Sleep Disorders Centre of the Antwerp University Hospital. He's president of the Belgian Sleep Society. And again, I'd like to thank him for his dedicated work on the criteria. And I think it's very important that he presents the detailed criteria because he was very strongly implicated in developing them. So as you can see on the right, the accreditation guidelines are freely available on the link that was sent to you recently by email. You should have all received it this morning. It's a freely available article, so click on the link and you can read the details of what we're going to talk about today. So without any further ado, I'm going to pass over to Dirk Pevenaggi, who's going to talk to us about why we needed to revise the previous guidelines. Dirk.
Thank you, Sarah. Well, I will start with sharing my screen. So I would also like to extend a very warm welcome to all the friends and colleagues within the field of sleep medicine that are attending this webinar. I also confirm that I have no conflict of interest other than being active in a big sleep research project. And my talk will be rather brief, and I have the pleasure to start with answering the question, why change? Why do we need new guidelines? Well, obviously, because there has been a big evolution. And since 2006, sleep medicine has grown a lot and has also diversified. So that's the reason why. And I would like to start with rehearsing some history, some actually very important history, because sleep as a scientific theme started actually in the first half of the 20th century. And it was in Europe, but also in the United States, that a lot of activities were going on. And really the first landmark publication was by Nathaniel Gleitman and his co-worker Eugene Aserinsky, who discovered very important information about sleep, REM sleep, for instance. So that was kind of the Bible for these early researchers. And very rapidly, the area of interest shifted also to the medical fields. Jones and co-workers were in the 60s already had a very important publication on drug therapy for insomnia. Insomnia is very prevalent now, but it was already a big problem, medical problem in those days. Most of us know that Christian Gilmino and Bill Dement from Stanford were the pioneers of respiratory disordered breathing, and they made seminal publications about the sleep apnea syndromes. Narcolepsy has been known for quite a long time, but it was Jos and colleagues from the Mayo Clinic who first described the triad of symptoms and really materialized narcolepsy as a clinical entity. And then with the other insert here, I would move to the medical political actions that have taken place in the United States, because it's in the United States really that the concept of sleep medicine was founded. So if you look at milestones in sleep medicine, we have to start with United States because big developments have taken place there. It started with the Association of Sleep Disorder Centers, which was founded already in 1975, and then continued to be the American Sleep Disorders Association in 1987, that finally came the American Academy of Sleep Medicine in 1999, and that is the scientific organization, scientific medical organization, as we know it by now. So big developments in the United States, and other countries, other continents have taken the US as an example to build and to expand the field of sleep medicine. But also in Europe, important facts have been established, and the credit goes to the German Sleep Society, or to Germany, who were the first to establish sleep medicine as a subspecialty in its own right that was accessible for several medical disciplines such as neurology, pulmonary diseases, but also psychiatry and others. As already indicated by Sarah, the ESRS has played an important role in publication of guidelines, the European Guidelines of Accreditation of Sleep Centers, which was published in 2006. And a few years later, the European guidelines about certification of sleep specialists. Now, if you would use a metaphor and consider sleep centers as a ship, then of course you also need to have crew and a captain to steer the ship. So the ship came first with the guidelines on accreditation of centers, and then we had the guidelines on certification of professionals. Now, in many countries, or in some countries in Europe, sleep medicine has become a subspecialty already. But I think one of the last major countries in Europe to establish this discipline was France, who established sleep medicine as a subspecialty in 2017. Now, this was the very first publication, and in 2006, and if we try to summarize this publication, hold on a second, yeah, it was actually a general description of what is needed in a sleep center, and a sleep center was considered a model, one-size-fits-all model to organize sleep medicine in different countries. Emphasis was put on specialists. What specialists can work in these centers? It was acknowledged that it's multidisciplinary by nature, but the emphasis was on specialist sleep medicine. The paper described several operational features of sleep medicine, such as the infrastructure, the logistics, the location. It was stipulated that it has to be a separate location within a hospital, and also described the equipment, staff, requirements, standard procedures, how to operate, and then also quality assurance and certification procedures for such centers. It was also indicated that it's important to have site visitation by peers. And this is a model that was taken from Germany, from the German Association of Sleep Medicine, who already had these procedures in place. And site visits were a very important part of accreditation procedures. And then it was envisaged that this paper would serve the accreditation of sleep centers in many countries, many European countries. And in this process, of course, national sleep societies and national health authorities play an important part, and there were some recommendations for these parties as well. Finally, there was a content checklist. If you want to do an accreditation procedure, if you want to do a site visit, there is a list of items that have to be checked, and this checklist was added to the publication. Now, if we look at what happened since 2006, since this publication, we see that, and this is a search on PubMed with the words sleep medicine in title. So this is the search strategy. You see that the number of publications on sleep medicine as a topic has grown a lot. It has expanded a lot. And for instance, in 2021, there were more than 80 publications with sleep medicine in the title. So this shows that this field is clinically relevant and is there to stay. But a lot of things has changed. That's why the accreditation guidelines had to be revisited and had to be upgraded. So I think that now sleep medicine has come in a particular situation where there is, it's a composition of diverse topics. The medical scientific content of sleep medicine is all these chapters that you can find in the International Classification of Sleep Disorders. And we know that there's plenty of resources for sleep medicine to be reinforced and to be accredited and certified. So the ESRS has done a lot of work in this area. There has been a publication of the Catalog of Knowledge and Skills, which has recently been revised with Thomas as first editor. We have within the ESRS, the sleep medicine textbook, or also the second edition, which was published a couple of years ago. And since 2012, the ESRS has issued examinations where people can show their skills, can demonstrate their skills, and be certified as an expert in sleep medicine. But of course, this is a more traditional approach. And in the meantime, we have evolved into modern times where the ballpark has changed a lot. We see that not only specialists are active in the field, there's actually kind of a proliferation of healthcare disciplines that have affinity with sleep medicine. There is a delocalization of care. It's not only the centers anymore that uniquely manage these patients. There's a lot of instances that are taking part. There is an increased connectivity. Now we have telemedicine that didn't exist in 2006. We have patients who know what they're after. They are quite vocal in asking questions to doctors. So self-efficacy of patients has improved a lot. We have the mobile devices that have entered our daily life, and we have, last but not least, the consumer technology that tells you a lot about the state of your body, including your sleep. So this is a new environment also for sleep from a medical point of view, and we have to take that into account. I think actually that we now some kind at the crossroads where we know that sleep medicine is important. We have several assets. We have a vast amount of knowledge. there is still important approval of scientific insights. And by all means, this is an interdisciplinary medicine. And the more disciplines involved, I think, the better this field becomes. And last but not least, there is a huge demand for healthcare with long waiting lists in many centers. This has grown also in recent years. So we have to face and address challenges. On the other hand, there are cutbacks in healthcare budgets in many countries. There is still parceling out of the domain, by which I mean that there is still a lack of integration of several disciplines into this interdisciplinary connection. And we note that there is need for innovation. The polysomnography, as we did it before, might change a lot. And above all, sleep medicine is personalized medicine, which should be affordable and appropriate. So healthcare authorities are also looking at us to see if these things are being done appropriately. So that's why actually we need to revise what we are doing, and the revision of the accreditation guidelines, in my opinion, really is a first step. So thank you for your attention.
Thank you very much, Doug. I think that was an absolutely limpidly clear presentation on why we felt we had to address the updating of the guidelines, which I have to say were excellent and we used in France for accreditation of our sleep centres for many, many years. I'd like to pass now to Thomas, who's going to talk to us about the overall structure of changes, because he was very much involved in bringing this new idea forward.
So I'm happy to continue the presentation. I hope you can see the introductory slide. So my talk will be the second one, and I will give you an overall picture of that. So based on what Dirk has said, the initial idea of introducing sleep center accreditation guidelines were that we were thinking we are an interdisciplinary field and we need to show the other medical fields that we follow quality criteria. And in order to show the quality of what we are doing, not only by the medical service, but also by the infrastructure, we were showing that the core of sleep medicine, which takes place in the sleep lab, follows certain rules. So in the beginning, we had just one size fits all quality criteria. But then with the change, which is really needed according to the change of technology, we see that some sleep labs do polysomnography, what we have always done, but some sleep labs do portable recording. We also see that the experts who were trained in sleep labs, some of them leave the sleep lab and start a private practice, but a private practice even still with a lot of sleep medicine knowledge. And therefore we were thinking, how could the field of sleep labs, sleep centers mirror this expertise? Because only part of it is the infrastructure and part of it is the knowledge, the individual person qualification or certification. So this overall picture was now done according to different types. Initially, when all the sleep labs started, there were different levels of polysomnography. This was of sleep recording. This was based on the investigation of sleep apnea diagnosis. There was a sleep apnea diagnosis using type 1 devices. So this is device oriented, like polysomnography. And the polysomnography was nicely specified, having the EEG and having having respiratory parameters, in addition EMG in order to see movement disorders. And this was traditionally done in the sleep lab, so-called level 1 type 1 kind of sleep recording. Type 2 of sleep recording was the same, but done possibly at home, so-called home polysomnography. Actually, this was mainly done in the northern European countries or for experimental conditions, like doing a polysomnography in space. So there are some interesting studies like that. But for sleep apnea, we only don't need to know whether a person is asleep or awake. Therefore, quite soon, polygraphy was developed. Polygraphy meaning that beside sleep and awake, the focus is on the respiratory parameters like effort to breathe, then the airflow needs to be recorded, oxygen saturation, and a cardiac variable, maybe body position in addition. So these are the type 3 polygraphy recorders, which are very prevalent and are used to diagnose sleep disordered breathing. They were always thinking, could we go more simple? Could we do that even ambulatory with just one parameter like oxygen saturation or only heart rate or just airflow? These are the so-called type 4 parameters, and we are pretty sure that this does not work well for sleep apnea. It's too little information. So it may be okay for insomnia when looking for actigraphy, but certainly not for sleep apnea. Based on this kind of equipment, the sleep labs, which were then revised, follow a similar structure, having this in mind. The structure are that level 1 and 2 sleep centers, they offer the full diagnostic testing in a laboratory-based setting, which means that someone, a sleep expert, is there and takes care of the evaluation. Level 1 is typically university affiliated and may even have full teaching and research studies in addition. So level 2 may be the more practical with less teaching and no research. Lower levels then would be level 3 and 4, and they may do outpatient and inpatient lab and mainly do maybe the polygraphy, but for some patients also have the polysomnography. So this was the idea of having different levels, but still a sleep expert, still a sleep physician on these levels. So it's really directed through the expertise of the somnologist. And level 3 may perform polysomnography, which I just mentioned, either monodisciplinary, just for sleep-related breathing disorders, or for restless leg syndrome, and perform polysomnography only. And with that, we come to a kind of different levels, which are explained in the new guidelines. The levels, they follow somehow the structure of the equipment. So level 1 would be the highest level, which is undergrad and postgraduate teaching and also research. So having all the different options like polysomnography supervised, maybe also have some devices going out of home. So unsupervised polysomnography and having polygraphy and having even one channel systems for other sleep disorders. Level 2 is almost the same. It still uses all the equipment and still does all the sleep pathologies. So we think of general community hospitals, it does polysomnography, and it's more the clinical service on a large scale. So these labs will not have a lot of research, maybe some smaller projects, but certainly and less teaching, maybe just on the roads, like doing the sleep recordings. So that's the level 2. It's really the service, it's the working force of the sleep medicine. Level 3 are those labs who are down the road said, I cannot cover all the sleep disorders. By our original training, we are neurologists, or by our original training, we are pneumologists, and we want to focus on one part of sleep disorders. So maybe just on sleep apnea, or maybe just on narcolepsy and hypersomnia, so really linked to the so-called mother discipline. So these are they are not multidisciplinary. They can be multidisciplinary and can detect sleep apnea, but and if it's a neurological lab, but they may not need to treat them. So it's a kind of recognizing the different disorders, but not taking care of all the implications. These labs can have ambulatory or inpatient polysomnography. They still need to do a full sleep study, still need to do a full polysomnography sleep lab in a way to have the supervision of the patients. Level 4 would be those sleep experts who said, I want to do a private practice. I want still to do some sleep recordings, maybe just at night, but they are no longer necessarily in a hospital setting. So they typically do just one kind of disorder, so typically respiratory disorder, but it could be also a neurological person who does just some insomnia and some restless legs kind of recording and says, oh, this patient is suspicious of sleep apnea, I send them to the pneumologist. So these are typically monodisciplinary, and they typically, most of them look for sleep apnea, but there could be also other disorders, and they do not have a full polysomnography any longer with nighttime supervision. Typically, they have the polygraphy and maybe even some wearables or devices which just record one kind of signal. So these are the different levels from the highest, like university, down to the general practice person with having a sleep expert as diagnosing the patients. I show this just in another way again. So the level 1, the sleep center with education and research, requires a certified sleep physician. And as you can see, all the levels require this person. So there should be a certified sleep physician in all the 4 levels. Then at least 5 years of training, which is required to do research and to do teaching, is restricted to the sleep to level 1. One can start this other kind of level quite immediately when leaving the university. So it's the idea after the university training, one can start a sleep medicine center somewhere in a community hospital or even go down to the general practice. Cardiorespiratory polysomnography, so with a sleep lab and supervision, should be available for the first 3 levels. It's not required for the sleep physician who runs the practice. Sleep medicine outpatient service is required for the education level, but maybe some community hospitals, they say we do not do outpatient service. That's in the hands of the general practitioner. So it's optional for the sleep medicine center in a community hospital. Same for a specialized sleep lab. So here we think it's optional, but of course in the general practice or in the privately run sleep physician, that should be in place. Titration of CPAP therapy or other therapy, of course, needs to be done in the level 1 lab and should be done in any sleep center, even in a community hospital. It may not be necessary in a level 3 hospital setting, because this could be a neurological center and they say, no, we don't treat sleep apnea. So same for the cognitive behavior and other therapies. So that's optional also for the sleep physician. Treatment follow-up studies, they are important for everyone, because even if a patient, maybe a complicated patient, had been investigated, diagnosed and treated at the university level, still the follow-up will be on a GP level, on a family physician level. Education is on level 1, and can be done at sleep medicine centers as well. Research is restricted to the level 1 because that's the distinguishing variable. With that, I'm happy to conclude the overall picture, and I like to invite you all to the Congress which we have at the ESRS and where we actually show the education and the research. Thank you very much.
Thank you, Thomas. That was an excellent and very clear presentation. I think we've all got a better idea now of this idea of levels. How do we adapt the accreditation of sleep activities to this changing world? So I'd like to pass now to Johan Verbraeken, who will talk to us a bit more in detail about the levels, the different levels. Thank you, Johan.
Okay, thank you, Sarah, for the introduction. I apologize that I cannot show my slides in the slideshow, but anyhow, the information is what counts. So, my topic is on the details of criteria for each level of accreditation of a sleep medicine center. This is my conflict of interest disclosure. So I received some grants for educational activities that I organize, and I also participate in some advisory boards, but they have no impact on this presentation. So the criteria for accreditation of sleep medicine centers can be summarized in about 11 key items that really summarize the essentials of the accreditation of sleep medicine. So the first 4 items are related to criteria for staffing of the sleep medicine centers. Then we have a 5th item that is more describing the facilities and equipment related to identification, communication headings, and protocols in the sleep center. Then there are some items on the technologies used in the sleep centers, including also criteria for the facilities and the bedrooms that are used. And then finally, there's also an item on patient care pathways, including so prior evaluation of the patients, follow-up of the patients, complete care from the start till the end, until the treatment, and then also about referral of patients. And then the last item is covering the patient reports, the documentation of the sleep study, and how to archive the sleep study data. So let's now dive into the details of these different items. So the first item is on the management of the sleep medicine center and the medical staff. So all centers, so from the first level to the 4th, must have a responsible physician who is member of the relevant National Sleep Society, who received initial sleep training according to the national requirements, or is having the ESRS somnologist certificate, and also having experience in sleep medicine. So the director of the center is responsible for employing an appropriate number of medical and paramedical personnel to manage, of course, the patient load and to provide high quality of care in every case. Now, what about the composition of the medical team? That is related also to the different levels of sleep medicine centers that we identified. So let's start with level 1 and 2, which have to be multidisciplinary, with experience of managing all sleep pathologies, including central hypersomnia. For level 3, also a multidisciplinary team has to be available, with experience also of managing all sleep pathologies, but with the exception of the central hypersomnia. And then finally, for level 4, this team is only monodisciplinary and is usually composed by respiratory physicians, but can also be another specialty like neurology and many others. The medical team also has to be trained. So all medical staff needs initial training, as also the director. The training has to be recognized by the National Sleep Society, or the sleep training can also be then tested and shown by receiving the European, so the ESRS somnologist certificate. And all staff also needs to continue medical education, usually as offered and approved by the National Sleep Society. Then finally, for the centers that are offering inpatient sleep studies, they have to guarantee that there is a permanent medical care, so at all times, and also in case of emergencies, then appropriately trained medical staff has to be available, but this can also be an attending physician who is not necessarily a part of the core sleep team. There are also criteria for technical staff, so covered in item 3.3. So the technical staff has to have sufficient knowledge of diagnostic and therapeutic procedures. The paramedical staff needs to be trained according to the National Sleep Society standards, and professional certification is recommended. So this paramedical staff also has to show evidence of continual education in order to keep the skills up to date. And in all centers who offer inpatient sleep studies, polysomnography level 1 and 2, and eventually also for level 3, also trained paramedical staff needs to be available throughout the whole night in order to monitor recordings. And they also need to be able to deal with emergencies. Then finally, for level 1 and 2 centers, the sleep technicians must be available also during the whole night and day to supervise vigilance testing. So that is related to the MSLT and MWT tests. The sleep centers from level 1 to level 4, so all need to have permanent secretarial staff in order to deal with questions from patients, for organizational appointments, and also for the management of the patient records. So that is a rather concise item. And then we move to the 5th item, which is describing criteria for the facilities and equipment. And here it is highlighted that all centers have to have easily identifiable. So that means with appropriate signage and having a heading, a communication heading in the letters or in the electronic communication tools containing so all the contact information. All centers also have to have detailed written protocols related to their tools and technologies and treatments that they offer to the patients. And these written protocols have to be consistent with national guidelines or with European or even American guidelines if national guidelines do not exist or not available. Specifically for the sleep studies covered in item 6, there is a description for polygraphy, so that's type 3, and for polysomnography, that means type 1 and type 2 sleep study. So for polygraphy, they must be performed using modern equipment capable of providing at least 4 good quality respiratory signals. And extended polygraphy adds additional signals, but systems, as you know, are heterogeneous and are there variable in use across Europe. So these extended polygraphs should be validated against gold standard polysomnography in the literature. So covered in the literature based on evidence-based sleep research studies, and have to be accepted by the National Sleep Society, and have to be performed and interpreted by medical and paramedical staff with specific training as already described. For polysomnography, they also have to be performed and interpreted following the American guidelines. And the equipment must be technically adequate and capable of providing good quality signals, which are free from artifacts. So that's quite detailed. The equipment must be age appropriate, so it has also be appropriate for studies in children. And the MSLTs evaluate the tendency to fall asleep, as you know, and the latency for rapid eye movement sleep. And these MSLTs must be performed and interpreted following the ASSM guidelines, and have always to be preceded by polysomnography. That is a very strict recommendation. And the MWTs also have to follow the American guidelines. So item 7 is a very concise one, which is referring to the local health authority guidelines for inpatient and outpatient facilities, more or less related to the bedrooms, and other criteria could be added as well here. But that is, here we rely completely to the national guidelines. Item 8 is also related to the facilities and to the inpatient polysomnographies. So for level 3, sleep studies should be performed in single bedrooms. So never in bedrooms with 2 beds, always only with 1 bed. And if there is a parent or a caregiver that is also spending the night, then there has to be, of course, an additional bed. So that is, of course, relevant in case of sleep studies in children and in disabled, handicapped people. So the bedrooms, have to be of adequate size. That means usually at least 12 square meters. It's a suggestion, but it is rather often the case. And these bedrooms should be equipped with adequate sanitary facilities in the room or close to the room. Also, some environmental criteria have been proposed, like the light excluding blinds, adequate sound proofing, less than 30 decibels at night and even during the daytime, which is following the recommendations of the WHO guidelines for noise, and also, of course, temperature control, adequate ventilation is relevant. The sleep rooms also need to have a two-way communication system and also a call system for emergencies. The equipment used should deliver simultaneous video recording and also electrical and biological calibration. And the center also has to perform continuous monitoring of the signals and of the signal quality, which has to be done in a separate room close to the sleep room of the patient. And this separate monitoring room has to have an adequate size. And of course, this monitoring has to be done by trained staff. Quite similar to the previous slide is item number 9, that is describing criteria for level 1 and 2 centers, which also perform MSLTs and MWT. What is extra in this item is that trained staff must be present day and night to monitor polysomnography and to perform the vigilance tests. Then item 10 is about patient care pathways, and is applicable to all centers. So patients should be evaluated prior to sleep studies. So never do a sleep study without seeing the patient before the sleep study. This can be done by the referring physician, by a referring physician, by the sleep center itself, during a consultation, or with a questionnaire that is also allowed, in order to identify the most appropriate management, which could be, of course, a sleep study in the hospital or outside. And after sleep studies, patients should be offered a follow-up with an appropriately trained sleep physician. So all centers should follow national recommendations for the care of patients with sleep pathologies. Okay, that is reasonable. And in the absence of national recommendations, again, European or American recommendations should be followed. Then finally, a sleep center should be able to offer complete care, so from the diagnosis up to the follow-up. And this, of course, depends on the level of the sleep center and of the competencies. So a level 3 or 4 center should promptly refer patients who require polysomnography or for the vigilance tests. And a timely referral has to be done to specific specialists, for instance, a maxillofacial surgeon, psychiatrist, ENT, or whatever. So in a timely manner, that is very important. In item 11, criteria are described for the patient reports, for the documentation, so the information that has to be included in the patient reports, and about archiving. That is all applicable to all sleep centers and sleep labs for all different levels. So what is described here is that the sleep study reports must be based on the result of a visual analysis of signals by a trained sleep study technician or by medical staff. And certainly the reports have to be validated by sleep physician. The reports or the report of the patient records have to be comprehensive and have to include the patient sleep history, as well as description of the relevant sleep and respiratory parameters. This report can be illustrated also by graphical summaries, by screenshots, and these reports have to be prepared within a reasonable time delay. So in case if the patient has been hospitalized, then also a brief discharge summary can be recommended. And finally, patient records must be filed, and raw data from sleep studies should be stored in accordance with the national guidelines. So usually that is based on the availability of servers and or an adequate serving system. Then, of course, everything has to be implemented, and for the implementation, a separate paragraph is included in this updated guideline, which is rather extensive, but in fact, the essentials of the implementation is a duty of the National Sleep Society. Then finally, we can come to the conclusions of this updated guideline, which state that the aim of these guidelines are to assure high-quality diagnosis and management of sleep disorders, the introduction of accreditation by level also aims to include sleep medicine practices that offer ambulatory PSG and PG. And again, so these national sleep societies are encouraged to adopt the new criteria within their accreditation frameworks. So I think altogether, these criteria are realistic and are feasible. Of course, in some centers, some adaptations have to be performed in order to fulfill all these criteria, but again, they are realistic and feasible. And I think many sleep centers and sleep labs and also private practices will finally receive this accreditation. So thank you very much. And I would like to offer the floor again to Sarah Hartley.
Johan, thank you so much. That was a really clear presentation of the situation. And while you've been talking, we've had several questions, and I thought I'd just highlight the questions we've had and encourage you to ask more questions. Firstly, we had a question from Peter Schipper, who asked about the role of teaching and research in level 3 and 4 centres, saying that, you know, gosh, we should really be doing it. And, you know, we're absolutely in agreement with you. We think that research and teaching are incredibly important in all centres, but it is not mandatory for a centre that's level 2, 3 or 4 to do teaching and research. If you do, we're delighted. If you don't, it's not going to stop you reaching the level that you should be at. So keep up the good work. Keep doing your research, please. Keep doing your teaching. We've had some questions from ESRS Karagiorgio. I'm sorry, ESRS, I probably mispronounced your name. ESRS asked some questions about the use of the term hospital for level 1, pointing out that in the US, sleep labs do not need to be in hospitals. And in fact, most of them are actually outside hospitals for health and practical issues. And, you know, we replied, ESRS, saying that I think we were using the term hospital to indicate a sleep centre that had inpatient beds and also had a mandatory access to emergency care. We, as you know, hospitalized patients who can be quite fragile. Certainly from the respiratory point of view, my hospital focuses very heavily on patients with neuromuscular disorders, and it's not at all rare that these patients are quite fragile. So it's all down to the presence of emergency staff and the presence of on-call medical and emergency teams. We use the term hospital. I think other countries will use different words for that. I hope that's highlighted a bit your question. And the other thing I want to say about that is that Europe is many countries, and each one of us has our own local health authority recommendations for how health services should be run. And so the important thing from the point of view of these accreditation guidelines is that your hospital or your clinic, your centre in your country must be in conformity. That's not very good English, must be, must meet the standards of your local country. That's incredibly important. The European Sleep Research Society is not there to tell you how to run hospital services in your country. And then we had a very interesting question from Shazwati Sengupta, which I think is an absolutely super question. I'd like to thank you for bringing that up, who says, hi, is accreditation applicable for non-EU sleep labs? Is there any process of acknowledgement and accreditation for non-EU sleep labs? And I think that's a fascinating question. In fact, we have the European Sleep Research Society has clearly put the role of implementation onto the national sleep services, but we know that some of the national sleep services are not yet able to offer accreditation services. So there's a potential role in the future that we can explore together to actually have some accreditation activities done centrally by the European Sleep Research Society. Now, we haven't gotten any further on this project, but I think it's a fascinating project. Definitely worth thinking about.
Sarah, if time permits, I have a question myself. Do we still have time for a short question? So I think looking at the guidelines, not being involved as a co-writer, I think that it's quite detailed and well motivated. So I think these new guidelines are really the new standard for the modern times. But I have a question regarding the organization of the accreditation process. You say, well, there is a role or a main role for the national sleep societies. But the question is actually how to accredit them. What are the processes that have to be envisaged? And will there be, for instance, on-site visits for centers of level 1 and 2? And does the ESRS now also offer a checklist to see what criteria have to be fulfilled?
I think that's a really interesting question, and I can see someone's put the thumbs up for that question, so I think it's an excellent one. Once again, it's up to the local national sleep societies to organise how they're going to do this. And we're actually, I know that in France at the moment, we're working hard on how we can actually put together new accreditation processes that actually meet these criteria. How we actually go about that, I think if you're going to accredit I keep wanting to say hospital, but now Eliassus has pointed out, I should say sleep centre. How are we going to accredit these sleep centres? And I do feel there's an important role for site visits. I think without visiting a site, it's difficult to imagine that. But during COVID, we started doing visits on Zoom, actually. And while I was very hesitant about this, actually, it worked really rather well. So I think we shouldn't, rule out the use of new technology to enable us, maybe not for a first visit, but certainly to follow up, certainly for reaccreditation visits. I've had fascinating visits of sleep centres with people walking around with their iPhones, showing me the contents of their sleep registration rooms and their cupboards and heaven knows what. So there's all sorts of possibilities these days. Susan Korn, I think we've got time for her question, says, when do you expect the new recommendations to be implemented? If the reaccreditation is due later in 2024, will there be a different procedure? Well, I think, Suzanne, that depends where you are, how far your National Sleep Society is moving forward on implementing the new recommendations. And another point which is important is that this description of different levels does not mean that national sleep societies have to offer accreditation immediately for every level. It may be that their means are not sufficient for that, and they'll accredit maybe level 1 and 2 and maybe level 3, and level 4 will have to wait until they've developed new systems. I don't know what the situation is in Germany and Belgium. I don't know if you have any comments on that. We've got more questions. I'm missing them. I've missed a question from Diana, who says, hi, we want to know if level 3 includes type 1 and type 2. Level 3 includes, you can do level 3 is basically about polysomnography. If you're doing polysomnography, you're either doing it in an ambulatory setting or in an inpatient setting. So yes, it includes type 1 and type 2. Stephen Emegbo asked about training requisites. Do we need to consider incorporating the training requisites described in addition to the guidelines set out by the national bodies for our undergraduate students? I think, Dirk, you're more of an expert on things to do, or Dirk or Thomas actually, on credentialing. Do we need to include this information in credentialing activities?
In training, well, that is still a matter of debate. So, for instance, if you want to sit the ESRS somnologist exam, the supervisor has to sign the paper that there has been training, appropriate training. But that is still not being expressed in terms of guidelines or recommendations. It is a very important topic, but we have not come up with proposals for that as yet.
Suzanne adds the information that she's in Germany, so I think contacting the local German representatives of your accreditation activities will help you know more about how things are going to work out for you. Jordan Cunningham says, might there be capacity for the ESRS to coordinate accreditation visits for countries with a tiny national sleep society? Or should individual countries approach neighbouring national sleep societies to provide visits? I think, again, that's a really interesting question that comes back to the role of the ESRS. One of our roles is to help the development of sleep services in countries that maybe have have developed a little bit slower. And I really think that we have an important role to look at. Dirk, you were about to...
Yes, I think this is a very relevant question because of the nature of the question, but also because it keeps on coming. This question is being asked by different people. So I think, yes, the ESRS should really consider how to tackle this problem. And maybe that could be a specific task for the Sleep Medicine Committee to see how can we coordinate things? How can we engage into helping smaller national sleep societies, foreign centers of excellence that have no means of being visited or being accredited. So it is really a question that is out there. It's a need. And I think that if you look, where should that be addressed within the bigger group of ESRS? I think it's Sleep Medicine Committee that may take up this issue.
Oh dear, Dirk, you're putting us right in the firing line, aren't you? So, last comment from Spectator Anonyme, which obviously I think you've come up in French on my system, who says, I would like to ask, it'd be good to have customizable guidelines per European country for the certification of health service, sleep centres. You know, you're absolutely right. The NSS take these guidelines, take this description of good practice at each level, and then translate that into implementable guidelines in your country, like we did in France, the 2006 guidelines, like Germany. We all know that every country has its certain elements that are unique, and it's the national sleep societies who know best how to implement overall European guidelines. But I think it's incredibly important that in the future we'll be able to say, I work in a level 2 sleep centre, I work in a level 3 sleep centre, I practice sleep medicine level 4, and that will enable us to talk across Europe and really, really enable us to better communicate about what we do, how we do it, and where we do it. So you know what? I've just looked at the time and I've realised we've terribly overshot the time that was allocated to us. There's lots more questions, which I will, sort of try and answer on the chat. But I'd like to thank everybody who's taken part. It's been absolutely fantastic to see how many people have been taking part. I honestly thought we'd have not very many participants, and I'm enormously encouraged to see how many people have connected and how many people feel that this is a vital subject for us to master. The world is changing and the ESRS is changing with it. So thank you very much. And thank you to our panelists as well, who've done a fantastic job.